Yes.
So, good evening and a warm welcome to all the dignitaries present here. I am Shrishti from Clearnet, assigned as the session assistant to ensure a seamless experience. Clearnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clearnet is the digital partner of this event organized by Cancer Kids Strength of Smiles Doctors Network Maharashtra. And the focus for today's session is rare tumors in pediatrics. So let us begin today's session, for which I would like to hand over to Dr. Saurav Srivastava. Sir, kindly proceed with the talk.
Good evening, everyone. I would like to welcome our dignitaries to the dais. First, we have my co-moderator, Dr. Omkar, who is a consultant pediatric hematologist and oncologist at MRH Children's Hospital, Thane. Then in the panelists, IGNO experts, Dr. Pankaj Dwivedi, the senior pediatric oncologist. Can you please move the slides, Shrishti? Yes. Dr. Pankaj Dwivedi, senior pediatric oncologist, National Cancer Institute, Nagpur. Next
Srishti,
slide,
you
please.
will have to move. You have to move slides, Srishti.
Next, please. Next, please. Yeah. Next, please. Dr. Nehal Khanna, professor at Tata Memorial Hospital, Department of Radiotherapy. Next, please. Dr. Basant Kumar, sir, the professor and HOD of Pediatric Surgery, SGPGI, Lucknow. And Dr. Chetan Anchan, who is Orthopedic Oncosurgeon, Speciality in Surgical Oncology in Mumbai. Please allow me to share my screen. We will be starting the case discussions with Ewing sarcoma first. We have got a couple of cases of Ewing sarcoma. The first case is of a 5-year-old girl who presented with pain and swelling over left suprascapular area, which gradually increased in size. It was associated with dull aching pain. Initially, it was associated with fever, and later the swelling also increased. And the patient presented after 1 month of the appearance of the swelling. The swelling was bony hard over the spine of the scapula. Overlying skin was not
Dr.
attached.
Saurav, we are not able to see slides. We are not able to see a screen.
Uh,
Presentation is not visible.
is it now, ma'am?
No, it is not. I can just see names of the 4 presentations slides.
Okay.
Can you reshare?
Yes, ma'am, I'm trying that only. Are the slides visible now, ma'am?
No, no. Is there any? Can anyone else see? Because I'm not able to see
No,
the
no, we
slides.
cannot see.
Achha.
We can just see the 4 headings: Ewing, sarcoma, and ovarian, and just yeah. Yes, now we can see.
Is it? Okay. Okay, so the first case is of a 5-year-old girl who presented with pain and swelling over left suprascapular area, which gradually increased in size and associated with dull aching pain. It was initially associated with fever, and later the swelling also increased in size. It was bony hard, and overlying skin was not attached to the swelling. The overlying skin was normal. The swelling was not mobile. There was restricted range of movement of left shoulder. The range of movement was found normal, sorry. Then MRI left scapula was done, which was suggestive of well-defined expansile bony lesion of size 5.7 to 4.5 into 2.7 centimeter, arising from a spine of a scapula and body of a scapula, with marked soft tissue component speculated to sunburst type of calcification. Findings differentials were Ewing sarcoma or osteosarcoma. True cut biopsy was done and it was sent for HP histopathology. It was suggestive of malignant round cell tumor, which on IHC confirmed as Ewing sarcoma. The child is undergoing chemotherapy at present. This was the first case. I will present the second case as well, and then we can go for discussion. Is it visible, the slides?
Yes.
It's visual. Go ahead.
Another case of 7-year-old female who came with swelling at left lateral back for 6 months. It was insidious in onset and gradually progressive, associated with pain and a low-grade fever. She underwent biopsy, which was suggestive of a small round blue cell tumor with nuclear pleomorphism, hyperchromatic nuclei, and rosette formation, increased mitotic activities. And the IHC was a CD99 FL1 bimentin positive. Ki67 was activity of 45 to 50%, synaptophysin desmin CD56 and CD45 negative. FDG PET was done, which showed a avid expansile mixed lytic sclerotic destructive lesion involving the left 11th rib with large associated heterogeneously, enhancing soft tissue component having extensions. CT scan was also done, which was suggestive of a expansile mixed lytic and sclerotic destructive lesion involving the left 11th rib with large associated heterogeneously enhancing soft tissue component 2.4 into 2.8 into 4.5 centimeter. It was awaiting the left dome of diaphragm, fat planes with adjoining left intercostal muscles, posterior chest wall muscles, and lateral abdominal muscles were lost. No other abnormal sclerotic or lytic lesions in the rest of the skeletal system. The child had undergone pre-op chemotherapy, neoadjuvant chemotherapy, after which we took for excision, and excision of the tumor was done with the excision of left 11th and 12th rib. These were the two cases, and Dr. Omkar, you can take over for the discussion part.
Yeah, sure. Thanks, Saurav. Okay, my first question before we go ahead with this the imaging strategy, my first question is to Dr. Chetan. How do we decide the site, the location for the biopsy? I mean, the incision which we take for the biopsy, how do we decide the location? And especially in patients, if in case now both these patients were in the chest wall, but if in case it is from the limb, where there is a limb salvage surgery also planned or attempted, then are there any special precautions one has to take?
Yeah. Can you hear me, Omkar?
Yeah, we can.
Okay. So, what was the location of the disease in the first case?
It was scapula, sir.
Well,
Scapula.
along the bony prominence in the suprascapular area, the swelling was there.
Right. Now, even there, the point of biopsy is very important. The whole idea of planning where you want to enter the lesion from, as far as the skin, puncture is concerned, is that you need to take that biopsy scar, not just the biopsy scar on the skin, you need to take the biopsy tract out along with the specimen when you're doing definitive surgery. And that's why the concern for the location of the biopsy scar. Otherwise, you need to take a separate incision and take it out separately, which may create problems when you are doing a salvage surgery, especially when it involves the extremities. And that's why there are very defined regions from where you can enter. But of course, every time we also consider the patient clinical scenario. You can't, just because it is mentioned that you have to enter from lateral only in a particular location, and if the mass is all medial, then what do you do? So the whole thing is you should know what kind of surgery this patient is likely to undergo and plan your biopsy approach accordingly. Having said that, with needle biopsies, we can always adjust things a little bit because it creates a very small area of contamination. But this is even more important when the biopsy is an open biopsy. Of course, that is something we don't really encourage anymore. I think there is hardly any reason today that we can't do a needle biopsy on most patients, not just for Ewing sarcoma, but for practically all diseases. It's extremely rare that we need to resort to open biopsy.
Okay. Okay. One more sub question to this. If most of the times these tumors come with a large soft tissue component when they report to us. So
Correct.
if we have an opportunity to take it from the soft tissue component versus the bone, which one will you prefer and why?
See, in fact, the soft tissue is a good representative area for the disease. So it's not necessary that you need to take it from the bone. And this is, specifically, especially when it involves flat bones like the ribs and the scapula. Entering the bone is a very difficult concept to accept because these are very thin bones. It's like if you enter from here, you may be already exiting from the other side. So the
Yeah.
sample should come from the soft tissue. The only thing that you need to look for is you have to identify areas of necrosis and avoid those areas. Especially in large diseases, the central areas will be necrosed. So if you do a contrast MRI, you will be able to identify areas which are, viable and areas which are necrotic. So sampling necrotic area will not give us any identifiable tumor tissue, and then we end up having to repeat the procedure.
Okay, yeah, that's a very nicely made point. That the necrotic area should be avoided, and if the soft tissue area is available for biopsy, one should go. In fact, you can avoid fractures also in the appendicular areas in
Absolutely.
case you go into the bone. So if you have a soft tissue component, definitely prefer that. Okay, my next
Correct.
question is to Dr. Pankaj. Dr. Pankaj, you're around? Dr. Pankaj? Okay, any of you can take that question. We can see it reflected on the screen. What kind of imaging strategy will you consider in the first patient for evaluation? And is there any role of bone marrow aspiration and biopsy? Now, in second case, we have done FDG PET. So, is there any role of additional bone marrow aspiration and biopsy in such cases, which has
So,
been the standard teaching practice to all of us for a very long time?
yeah, so to answer your first question, we have to consider for the two type of the images. One is the local images that will, I think, will help in surgical management as well. Another is to see the metastatic disease, what is the extent of the disease, whether it's a metastatic or non-metastatic.
Hmm.
So in our practice, we do the MRI of the local site most of the time if it is a limbs involvement. And then it is definitely followed by the PET-CT scan. We are not doing if the we have no this thing, I don't know how much it is correct, but we are not doing if it is PET is not available on a marrow, or we don't find anything on a CBC. So I routinely don't do the bone marrow aspiration or a biopsy. Other make.
Okay. Okay, yeah, yeah. So there is data on bone marrow biopsy and aspiration with FDG PET comparison,
Yeah.
and they have shown that the detection of bone marrow metastasis, which was demonstrated, pooled 100% sensitivity and
Yes.
96% specificity and 75% positive predictive value with 100% negative predictive value. So in the era of FDG PET, I think one can skip bone marrow aspiration biopsy completely
Yeah.
in these tumors unless there is a clear-cut marrow involvement which we want to demonstrate microscopically. My question about the imaging strategy was also to highlight the point of skip meds, especially the one which we see in the long bones. So can you comment on that? So in case we don't have an FDG PET facility available and only MRI is the one which is considered, will you consider the entire bone or will you consider only the part involved? Because a
No,
lot
so
of times what we see is the patients are being referred with the MRI of the affected area, but they most of the time skip the other areas in the bone.
yeah,
And
so
yeah,
as primary what teaching is this one joint above, one joint below, like
yeah,
this.
great.
Yeah,
Yes.
that may be the sufficient. And if you have the definitely must have the CT scan. So CT thorax will help you in,
Yeah.
because most of the metastasis is there in a lungs. So then you will get, and you will know whether you have to do consider for the PET CT or not. But at least if you don't have the PET CT, you can do like this: MRI,
Okay.
one joint above and below, and the CT scan of the thorax.
Okay.
Yeah.
Okay.
Can
One,
you
Yeah.
hear
one
me?
point, one point I would like to
Hello,
make is,
Omkar?
Yeah. Yeah. Please.
yeah, Dr. Chetan here.
Yeah.
See,
Please, Dr. Chetan. Yeah.
yeah, one point I would like to make about imaging is, as you rightly pointed out, whenever we image a particular bone for any bone tumor, the entire bone should be imaged, right from the joint above to the joint at the other side.
Yes.
It not only helps in looking for stiff lesions, it also helps in planning our strategy for treatment, especially related to surgery, and also helps us in early counseling of the patient. Especially when it comes to children, there are a lot of challenges to limb saving procedures, and that is something we prefer to sensitize the parents, the family early, so that by the time they come for surgery, they are sort of composed and settled and are more willing to accept. Otherwise, it
Yeah.
comes as a big shock when they, are ready, when the chemo has worked and the patient has recovered very nicely. And in fact, a painful patient has now started playing, and suddenly you now say that you will do something which will again,
Yes.
lead to a compromised function.
Yeah.
The
Yeah.
other
That's
thing is,
huh.
besides MRI, as a surgical oncologist, for me, the most important image at presentation for any patient with bone tumor is a good quality X-ray.
Yeah.
So a lot of times, this is something which is
We
missed.
yeah.
Many patients come to us directly with an MRI because they feel
Yeah.
that's the advanced investigation. But MRI gives us anatomical information. It doesn't give us a lot of information about the actual disease process. It's always comforting and sort of, gives us sort of completion of the workup of this patient. Whenever we see the X-ray first, make up our mind about what we are dealing with, and then go for the advanced.
Okay. So, but any additional advantage of X-ray over MRI, if in case the
X-ray has diagnostic value,
Yeah.
significantly important. In fact, a good pathologist would never report on a histology without looking at the X-ray of the patient.
yeah. Okay. Point well taken, sir. No, there is one question to you, directed to you from B.
Yes.
Kalavant. He's asking needle biopsy meaning true cut biopsy. So can you just elaborate on that?
Yeah, that's a good question. Now, you can do biopsy either with a true-cut needle or with a J needle, that is a bone marrow aspiration biopsy needle. That depends on what kind of tissue you are dealing with. If it is a large soft tissue mass and your, true-cut needle is able to, capture tissue in that, that is good enough. But if you have to enter bone, your true-cut needle will not be able to do that because it will get damaged. So you need to use a J needle, which is a thicker sort of a hypodermic needle, but much bigger and thicker, with which we are able to core into the bone and take out cores of tissue.
Okay, okay. And I think Dr. Kalavant is asking another question. You're asking specifically for Ewing sarcoma, right, Dr. Kalavant? Role of brain CT necessary if we have omitted PET CT. Pankaj, you want to take on that?
Yeah, yes,
I
in even sarcoma.
Yeah. So
So that is not in a
yes,
like this. If you even do the PET CT is not sensitive for the brain lesion, because
correct.
the higher metabolism or something. So if you have nothing in a lungs, it is rare to go outside. So if symptom is present, definitely you do the MRI or a CT brain. Otherwise, there is no need as a workup to do the CT scan of the brain in every case of the PNAT.
Absolutely. So metastatic workup generally involves the bone assessment as well as the lung assessment. Yeah. Point well taken. There is, do we have imaging pictures, Dr. Saurav? I haven't really seen the case.
For this case, no, sir. I don't have, unfortunately.
Okay, okay, fine, fine. Uh, uh, Fine. So, I cannot see any other questions in the chat box. Anyway, so my next question is to again Dr. Pankaj. Uh, Most of these tumors, the Ewing's type of tumors, the IHC report, especially in cities like Mumbai and Nagpur, where you practice, you often get these reports as BCOR positive or EWSR1 with so and so fusion. So the Ewing's which are translocation negative. Okay, the Ewing sarcoma which are translocation negative. Can you just comment on that? And do you really have a different strategy to manage them?
No, no, no. So good question. Actually, we have a lot of confusion about that, and there are a lot of paper. So if you go by the BCOR, so there is the one paper which says that if it is a non-metastatic, even BCOR, they do same as a non-BCOR positive cases. So in practice, we don't take it as a whether the translocated or is a BCOR positive this thing. So that is my practice. We don't change the treatment modality based on this, and most of the time we don't do the translocation studies in most of the cases actually right now, because we don't have any target for that.
Okay. Okay. So yeah, so that's an important point. Most of the BCOR varieties even do well. Not really an experience with cis rearranged sarcoma, because a couple of patients which we had, they did not really do well as compared to the BCOR variety or the usual translocation positive Ewings. So yes, these there is very limited data on these three different varieties, which are ESRW, EWSR1 non-ETS fusion variety, cis rearranged sarcoma, and sarcomas with BCOR genetic alteration. These are the translocation negative Ewing sarcoma. And because of limited data, as of now, the standard of care is to treat them on Ewing's protocol and not otherwise. Dr. Nehal, you wanted to make a comment on brain CT. Please go ahead.
Oh, I've already messaged.
Okay. Yeah. Okay. Yeah.
No, I just, if there are very junior people, listening to this, you have to understand that any metastatic workup depends upon the way a pattern of relapse is for a particular tumor. So, if for a soft tissue sarcoma, it is only pulmonary meds. So, the only thing you target is lung, you do an NCCT thorax. For Ewing's, it is bone, bone marrow, and lungs. So, you have to do an NCCT thorax, you have to do a bone marrow, and you have to do a bone scan. But if you do a PET CT, it's like a one-step non-invasive invasive investigation for everything, and it's quite comfortable. And sometimes Ewing sarcoma may have soft tissue mets, atypical metastasis also. So PET
Yes.
CT really helps.
Yes.
And now most of the even tier 2 cities have access to PET CT.
Yeah,
So I think instead
absolutely.
of getting three different investigations, it's always better to do a PET CT.
Yeah,
Very
one single PET
convenient.
CT. Absolutely.
Yeah.
Very, very, very nicely made point. Now, since we have Dr. Nehal and Dr. Pankaj both on board, these tumors, the most important treatment is the local control. Okay, so we give a neoadjuvant therapy also to shrink the tumor, but ultimate goal is to have an R0 resection, and as far as possible. So my question to both of you: which is the best modality for local control, surgery or radiation? And is there any prospective data to define superiority of surgery alone over radiation alone? I mean, I'm specifying only the single modality, not surgery plus radiation, which is also being considered in
Mhm.
some cohort of patients. But as far as single modality is concerned, is there any superiority of surgery alone over radiation alone? Dr. Nehal, you can start.
Yeah. So if there's no head-to-head randomized control trial between surgery versus radiotherapy, and that is not going to happen. And whatever data that comes is from retrospective series, which have their own selection bias. So if you look at that data, the local control outcomes with definitive radiotherapy is almost 10 to 15% inferior to surgery.
Okay.
And why is that so? If you see which patients are referred for RT, they are all those bad tumors, larger tumors, unfavorable locations, patients who have not responded to chemotherapy. These are the patients in whom the outcome is any which ways destined to be inferior. But you have to understand that if given an option between surgery and radiotherapy, surgery remains the preferred local treatment. If surgery is not feasible, in the sense if the tumor is unresectable or if the tumor is resectable, but the surgery is associated with significant morbidity or loss of function, then definitive radiotherapy is considered.
Okay. So
Dr.
yeah, that was,
Pankaj, would you like to add
yeah,
on
Dr.
to
Pankaj,
this?
we would love to hear from you.
Yeah, so it is rightly said. Rightly said. If you see the pelvic tumors where surgery is not possible, so the RT is only going to be this thing. And if you see the sub analysis, if I see my patients, since I have using a interval compress, so this will actually supplement in a better result. So we are giving a chemo as per an interval compress as well as the RT to the local site without doing the surgery of this site, and we don't find any difference in there is no increase in the relapse. So I second this statement of Dr. Nehal. It depends the feasibility of the surgery, and if it is obviously if surgery is not feasible, then RT is the best option. But head-to-head comparison is not there, except for few where they are more skewed towards the surgical outcome is better than the radiation. So that is there.
Absolutely.
Yeah.
So just to summarize what both of you said, and
Omkar,
yeah, sorry.
yeah, before summarizing, I'm Dr. Basant, I'm pediatric
Yeah,
surgeon.
Dr. Basan, please go
Yeah,
ahead.
I second both Dr. Pankaj and Dr. Nehal both. That is definitely surgery is the best for local control. I have seen few patients who was operated somewhere else in periphery location. They have only surgery. They came with some other disease, and they were afraid that they have some kind of malignancy that recur, but they never received any chemo or any radiotherapy. And I realized that this was not the tumor, that is some benign pathology. So it is definitely. And one more thing I want to add in Dr. Nehal's report, even in pelvic surgery, if we do R1 resection or R2 resections or simple debulking surgery, chemotherapy, radiotherapy will be more effective if tumor mass is less there.
Okay.
That
Yeah.
is my quote.
Yeah.
I would like to comment on this. In
Yes.
fact, there have been studies which have said, the ICAS and the European studies, they have said that there is no role of a debulking surgery in pelvic tumor. Look, you have to understand that if you have debulked, that is residual disease is there. The dose of radiotherapy does not change. The
Yes,
patient
yes.
has to bear the side effects of two modalities. So it is better to consider
Yeah,
definitive radiotherapy if you feel it is going to be a planned R2. Look, you felt it is resectable and then on table you saw that it is not resectable, better close and come out instead of doing a debulking surgery. So there's no role of debulking surgery in Ewing sarcoma.
yeah, Dr. Nehal, I fully agree with you. There is no role if you don't, if pre-operatively you don't consider you can remove the whole tumor, you should not go. But many times if you go and there is bitter, little bit tissue is there, and you cannot remove that because without sacrificing a vital structure, you have to leave that. In that scenario, I am talking about that scenario.
Yes, yes. So, for example, if it's the first rib or the second rib Ewing sarcoma, where the brachial plexus is involved, I'm giving a hypothetical situation.
Okay.
You know that you
Yeah.
will be able to resect the first and the second rib, but you may not be able to resect the tumor that is encasing the brachial plexus. So, instead of removing the ribs and leaving behind the brachial plexus disease, it's better to leave, to not to operate, and let us give definitive radiotherapy to the entire disease. This is
Okay.
a non-contaminated area. It is easy for us to give radiotherapy. The patient will not have morbidity of two modalities. This is what I'm trying to tell.
Okay.
So I agree.
Okay.
There is some rationale behind that. If the tumor burden is more, radiotherapy is not that effective. It's really not like that. Now, with dose escalation, you can really take care of a large volume disease also. So the side effects are less and the outcome is good. If you look at the dose escalation local control, it is above 75%. So in a very controlled environment, you can get that kind of outcome. So a planned debulking is not advisable.
Yes, agreed. Agreed, ma'am.
So can you elaborate more on the Dr. Nehal on the radiation therapy dose escalation in unresectable Ewing? I mean, you have a beautiful paper on that. Would love
Hmm.
to know more.
So,
Yeah.
this publication from TMH, there were almost 100 patients and they were randomized between the conventional dose, which is 55 gray, versus escalated dose, which is 70 gray. And the local control was almost 50% for the conventional and 75%, 76% for the escalated arm. So it's not that every single site requires dose escalation. In certain areas like, base skull, paravertebral, it is very difficult, very challenging to, deliver 70 gray.
Hmm.
But in certain sites like pelvis, where there is a large residual disease left behind, these are good cases for dose escalation. And now with conformal modality, I'm not saying proton therapy, but even with good photon therapy, you can have minimal side effects for pelvic tumors if you plan for 70 gray.
Okay. Yeah. Just to summarize, you have been using in Tata pre-op radiation in cases which are unresectable to make them resectable and then followed
That's
by surgery.
okay. So now that's a very good question, but very difficult one to answer. So I'll tell you, as compared to soft tissue sarcoma, pre-op RT is very rarely used in Ewing sarcoma. And why is that? It is because they are so sensitive to chemotherapy that whatever shrinkage you wanted
Hmm.
to happen happens with chemo itself. Very few cases, barely, once in a year we'll have a case in TMH wherein our surgeons would say that, there has been good response, but if the response is slightly more, we'll be able to resect it. So what we do is we know that, chemotherapy and radiotherapy response kind of goes hand in hand. So we know that there is a chance that with pre-op radiotherapy, we'll be able to push in a good dose and hopefully we'll get good response and the surgery is feasible. But we also keep it at the back of our mind that this patient may not be a case for surgery. So what we do is instead of giving lesser dose, we give full dose, conventional dose, 55.8. If surgery happens, well
Okay.
and fine. If surgery doesn't happen, at least we have given full dose. Because by the time you evaluate for response, plan for surgery, and tell us that, now we can't operate, you complete radiotherapy. Now that is terrible. So we, kind of, work in the midway.
Okay.
So
Okay.
we kind of give full conventional dose and long-term side effect wise, intraoperative side effect wise, not much of difference between 45, 50 and 55 grade.
Right, right. So again, my question to you, Dr. Nehal, is in case of a surgically poorly resected tumor, where there is a lot of residual disease, or where
Mm.
there is a lot of there is hardly any necrosis which is achieved in the on the specimen. In such cases, what dose of radiation will you consider?
So still the conventional dose of radiation is 55.8, but as you said, this patient has a large residual disease. Um, we generally don't look at, that necrosis part, but a large residual disease would of course mean that it's not cystic and it's all solid. That means it's not responded that well to chemo. So we do consider escalated doses. We give 70.2.
Okay, okay. That's important point to note. Dr.
Hmm.
Basant, my question to you is, does the timing of local control carries any impact on outcome?
Yeah, please repeat the question. I could not hear
Does
it.
timing of local control, generally what we follow is a dose dense or a non-dose dense chemotherapy regimen followed by local control. So local control timing, does it matter on the impact? Does it affect the impact or the does it have an impact on the outcome?
Yeah, definitely it has impact on outcome. If you control, local control is early, definitely there will be uh, chances of metastasis or well-being of child is good. And if hello,
Hello. Yeah, we can hear
hello,
you, sir.
sorry,
Yeah, we can hear you.
yeah, yeah. So your question was timing of local control. Am I right?
Yeah. So the
So
timing of local control, what I mean by that is, we give a set of chemotherapy and then
yeah,
we wait for
definitely.
the local clearance.
Yeah, usually in our routine practice, if a tumor is non-operable, we give chemotherapy and see, look for the operability. Usually, after a few cycle of chemotherapy, we evaluate after 6 or 7 cycle if it is operable. As early as possible, we operate to take the local control.
Okay, yeah. So that is an important point sir has made. Earlier, the local control achieved, better it is. So there is data which
Overall
is
outcome.
shown that patients who initiated local therapy at 66 to 15 weeks had a 5-year OS of around 79% and 10-year OS of 70%. And patients who initiated local therapy after 16 weeks had a 5-year OS rate of 70% and 10-year OS rate of 57%. So there was a significant difference. So yes, it does matter. Dr. Basant, question to you. Do you consider neoadjuvant setup of chemotherapy in all your patients, or do you consider upfront resection in any of your subgroup of patients?
Yeah, this is a very nice question, and it will depend on clinical scenario. If child is present little bit early, and if we found that we can make it R0 resection easily, we go for resection. And if we have any little bit doubt, we go for chemotherapy, neoadjuvant chemotherapy.
Okay. Dr. Chetan, any comment on that?
Yeah, so I would disagree there. In fact, in Ewing, when we know that it's a chemosensitive disease, the rule that we follow is always start with chemo first, and whenever the patient has completed the NACT cycle, that's when we would plan the surgical management.
So,
Yeah,
Yeah,
Dr.
There is
Pankaj.
one.
Yeah, Dr. Basant, yes.
so I
Good.
want to add in this.
yeah,
It's a PNT is a it's a systemic disease, right?
Yeah.
And
right.
you, as the rightly said, that as per if you see whatever is the protocol, I'm not aware any such protocol where they upfront do the local therapy and then go for a chemotherapy. So it is always whether you go with the COG interval compress, whether you do the EFT 2001, they all give the neoadjuvant chemotherapy and then they see the response and consider for the local therapy.
Yeah. I make little bit comment over it.
Yeah.
I am talking about biopsy versus surgery, excisional biopsy versus surgery. So this, if a tumor is very small, I never go for a two-cut biopsy or needle biopsy. I go for surgical resection, the whole the tumor. And if it came out as a Ewing sarcoma, then go for chemotherapy. That was my concern.
So if it is not a, sir, I'm sorry to say, but if it is not a Ewing's.
Yeah. So, no, whenever we remove sarcoma, it is a wide excision, and wide excision means it always comes with some removal of normal tissue, which might have consequences on the patient. The whole idea of biopsy is to know what we are trying to treat. So personally, I would never, advise a excision biopsy on any patient, however small the lesion. Always first understand what we are treating, and then, go about planning how to go about treating it.
Yeah, Chetan, Dr.
Yes,
Chetan, sir.
Yeah.
yes,
Just
Yeah,
just
Dr.
my
Basant.
comment is that if there is a small lesion in the extremity or scapular region or in a chest wall lesion, and if you can resect it easily, it is not involving major organs or vital organ, and with a wide margins, then why we should go for two-cut biopsy? It is on peripheral location. We can excise it easily, and it should go for histopathology as a whole. Why two-cut
yes,
biopsy?
Can I make a
If we
comment
don't.
here?
Yeah, please, Dr. Nehal.
Can I make a comment?
yes,
Yeah, please, Dr.
So,
Nehal.
so I've worked in pediatric surgical department also. Sometimes there are lesions which are very, very small and they present, and when we excise it, and there's a weird diagnosis, as in it can be a malignancy. So that is a situation which probably Dr. Basant is talking about.
Yes.
Otherwise, in any lesion where we are suspecting a malignancy or a solid tumor, generally we get soft tissue ultrasound done. So if there is a suspicion of malignancy, it is ideal to do a biopsy first, then to try to excise it. So basically, they are very, very small lesions which generally in OPD can come, and HPR can show that it is an Ewing sarcoma or any other malignancy.
Yeah, so these are the lesions Dr. Basant is saying that after resection, you come to know that these are Ewings. And because
Probably.
they
He's talking
began
about
with as
very,
a very small lesion, but
yeah.
otherwise, generally the flow of event is to give neoadjuvant chemotherapy in view of it being a systemic disease and a chemosensitive disease, followed by the local control, which should be done within between 6 to 15 weeks to have maximum outcome. I think that
Okay.
that I can summarize that. I think all of us agree on that, correct?
Yes, agreed.
Yeah. So my question, Dr. Pankaj, to you is, as far as chemotherapy is concerned, Okay, there are different protocols which many centers are using. So can you comment on? I mean, there are European subgroup, European protocols, and there are the COG studies which have given a dose dense, interval compressed dose dense protocols. In Tata, we have seen being the non dose dense regimens being used, and they have an excellent outcome. They have, Dr. Badira has published that paper also. So which one is the best one to use? You feel what do you use at your center,
Yeah.
and how do you decide on that?
Yeah, so this is very actually a relevant questions when in a practice. So when I was in Tata, we were using IFT 2001 protocol for all. This was the
Yes, which is a non-dose dense protocol.
non-dose dense protocol.
Yes, yes,
It is a spread about around a 48 weeks protocol.
yes.
And once this COG trial come up, the interval compressed. So interval compressed definitely shows a good outcome in localized. We must remember this is for a localized tumor, not for a metastatic. In metastatic, whether it's a dose compressed or it's a spreaded one, they have a similar outcome. So
Yes.
interval compressed is better. The compliance is better. You should also think about the compliance and the this regularity of the chemo, because it completes at due time. So I will prefer in a localized tumor, we'll go for the interval compressed. And we have a data of around 50 or 60 patients who have undergone you asked for my experience. So undergone this interval compressed chemotherapy. Compliance is mostly is 95 to 96%. Only one patient I remembered who actually left. Otherwise, and the results are quite good. So if you have a facility at your site, I will prefer to go for a COG interval compressed protocols.
Okay.
Yeah.
Yeah. So since you mentioned about the localized disease, we see that the Americans do not, further stratify the localized disease, whereas the Europeans further stratify the localized disease into those which are good responders and those which are bulky to begin with. So can you just elaborate the differences in the different approaches, Dr. Pankaj?
Because I follow this COG, so they have their set of point where you consider them. For example, few lung parenchymal nodules they are not taking as a high risk, right? But pleural based lesions they are taking as a high risk, and they are not actually offering the interval compress in those patients. So this is as per the protocol. You will find a different types. So once we go through the protocols, then we come to understand which protocol we should use. So that is there. I am not very much aware of the very fine details of the European they are following. So if you have those points, then definitely you can share.
Yeah. So just to make a note of it, the Europeans in their Ewing 99 and the 2008 study and the 2012 study, in fact 2012 study showed that the before 2012 they have been using wide regimen VIDE, which was very less intensive. As compared to the COG regimens and which was VCD followed alternating with IE, and that regimen definitely had much better EFS and OS rates as compared to the wide regimen. And in 2012 Ewing trial, they in fact showed that the VCD-IE alternating is definitely considered better. It is more efficacious and less toxic also to the patients when compared to the dose less intensive dose regimens. So yes, as you rightly mentioned, the COG protocols are using a dose dense regimen, and they're turning out to be better in comparison to the European approach. Now, as far as response to the treatment is concerned, Dr. Nehal, Dr. Basant, Dr. Chetan, and Dr. Pankaj, this is a question to all of you. We give a neoadjuvant setup of chemo and we take out the tumor after surgery. We see that there is necrosis which is less than 90%, and I mean, how do you approach in a dose dense setup? And Dr. Nehal, you are practicing at Tata with the non-dose dense regimen. So how do you proceed with the non-dose regimen, dense regimen in such scenarios? Dr. Pankaj, you may start.
Yeah, so we don't change our treatment based on these findings. Means if you see the prior protocol also, they if uses a post-treatment changes, if they are using another chemotherapy, then there is no advantage in OS or EFS. So chemotherapy wise, we don't change the treatment. We continue with the same treatment.
Okay.
Dr. Nehal can comment on it.
Yeah, I agree. I completely agree with this. So we
All right.
don't,
All right.
we go ahead with the same non-dose dense protocol. But I would say in adults, for example, in head and neck Ewing sarcoma, Dr. Kumar Prabhash's team is actually using the dose dense one, the 2 weekly ones.
Mm-hmm.
So I guess, we have to balance and, figure out what we are comfortable with, what, toxicities we'll be able to deal with. And I don't think there is much of a difference in the response evaluation. We evaluate response between 8 to 10 weeks and then schedule the local treatment.
Okay. So the point to make here is that in Ewing 99 study, I think they had used the high dose therapy as consolidation for patients with the poor response to initial treatment. So the poor responders. So they had given the high dose chemotherapy in the form of stem cell rescue and Bumel. So these were the non-intensive regimens. So in dose dense regimens, as per COG data, there is no change in the treatment irrespective of the response to the treatment. Whereas the Europeans have a stem cell rescue and a high dose chemotherapy setup, which has shown the benefit and advantage when given to the poor responders.
Okay, there is one comment.
Yeah, please go on.
See, those patients, they are the metastatic patients, and actually a non-intensive chemotherapy is giving like a to see the sensitivity in vitro. In vivo. So there is an advantage if they show a good response, though they are a metastatic, to consolidate with them a high dose chemotherapy and autologous stem cell. If they are previously also not chemosensitive, there is not much advantage. There is a good paper about the autologous stem cell and high dose chemotherapy in cases of metastatic Ewing sarcoma. So I think that should be highlighted here, because that gives you the idea about the in vivo sensitivity of the chemotherapy.
Yeah. So this Ewing 99 also had two subgroups. The one was the poor responders, and the second group was the metastatic disease. So the first group did show good response to the high dose chemotherapy as a consolidation with stem cell rescue. Whereas the metastatic, as you rightly said, did not really have an advantage over it. Dr. Nehal, in a post-op case, what all generally, can you just enumerate the indications for the benefit of all the people? Indications for radiation therapy, which is a cohort of patients which you will consider radiation for?
Look, it's again a very difficult question. It's a long answer question, but I would just like to summarize in a few sentences that, first, it's an MD-JC decision. Just the radiation oncologist cannot decide I'll give post-op RT, or the surgeon cannot just decide that, I will insist on post-op RT. The surgeon, the radiation oncologist, the pathologist, the radiologist, all of us, sit together. Now, I'm lucky that I'm in TMH, and, we all of us sit together twice a week and we discuss every single case of post-op RT, and we decide accordingly. But I would insist that if you are, freelancers, or if you are in institutes which does not have that kind of an MDJC culture, your colleagues are just one phone call away. The radiation oncologist should just talk to the surgeon can just talk to the pathologist, have a word about, how good the margins have been. So the thing is, post-op RT is given to cases quite intuitively, which have higher chances of recurrence. So which tumors will have high chance of recurrence? First, which were larger tumors to start with, so large soft tissue at the time of presentation. Patients who did not have that kind of margin, not wide margin. So, close margins are an indication. Now, there are certain sites like head and neck, like chest wall Ewing sarcoma. The kind of margins that you will get in an extremity, you will not get in such sites. So in such sites, we err towards giving more post-op RT than we would plan to. Now, there are certain indications, certain cases wherein you would want to avoid RT. When it's a young child, where the response has been very good, and if you irradiate the tumor bed, you would have fired the growth center also. So you would err towards not considering radiotherapy. Now, there is one very important point you need to understand. There was this paper by the Euro Ewings. It was published, I think, 2022.
Okay.
It actually discussed the role of post-op RT. and it had the largest number of cases that can be taken with a very good statistical model they evaluated. And in fact, as a surprise, this paper showed that patients who I'm sorry, I'm getting a call in between. That's why that's a bit of a disturbance. So it was a bit of a surprise when it said that patients who had 100% necrosis had the maximum benefit with post-op RT.
Oh, okay.
Maybe because these patients will not relapse systemically and have a higher chance of relapsing locally if the local treatment is not optimal. The other thing this paper said was the outcome of local relapse was barely 20% in 2 years. So, how do you optimize local control? You do good surgery and you offer post op radiotherapy. So, in fact, after that paper, quite a lot of centers who were not giving post op radiotherapy started giving post op radiotherapy. So, that's a very good paper. I would insist that all of you should read. But
Absolutely. Yeah.
again,
So
just one thing, it's an MD-JC decision. All
Sorry
of
to
you sit
interrupt,
together
ma'am.
and decide.
We need to move to the next case as well, which is just.
Yes, please do
I'm
that.
very sorry to interrupt you.
yeah, totally fine, Dr. Saurav. No, just to
Just
summarize,
one small doubt I had regarding
yeah,
Ewing's. It is the extraskeletal Ewing's, that is soft tissue Ewing's. So one of our patient had this in the perianal region, in the ischiocrectal fossa to say, and she was given chemotherapy, and now the tumor has disappeared completely. It is not evident clinically nor on imaging. What to do next?
So this is again a difficult scenario. So if surgery is so, if you can't see anything, what do you operate upon? If it was bone and it showed complete response, you still had, some anatomical idea of that place. So in case if the surgeon is unsure about what to excise, I would say this patient should receive radiotherapy.
How will you map, ma'am, for the radiotherapy? What all areas should be given? Is it based on
Yes,
the
yes. So we have
pre-chemo?
guidelines.
Yes, ma'am.
Yes, we have guidelines which say that we have to incorporate the pre-chemo extent of the disease.
Thank you so much, ma'am. Thank you
So
so much.
we may not use dose escalation in this patient, but we would surely give standard dose 55.8 to the pre-chemo extent of the disease.
Thank you so much, ma'am. We'll move on to the next.
yeah, I think, and Dr. Saurav,
Thank
we have
you.
answered most of the questions which are there in the chat box also. We can surely move to the next case.
Yes, sir.
Yeah.
Definitely.
Before we move to the next case, can you tell us what happened with the two patients which you showed us? How did you proceed with the patients? Did you? Yeah.
The rib was excised actually after giving the chemo. We could achieve a negative margin as well on the post-operative histopathology report, and the child is completing now the post-op chemo.
Okay. All right.
She is doing fine. The
Okay.
first one is undergoing chemo at present. So
Okay. Okay. We can move on to the next case if, yeah.
yes, sir. So next we have are the slides visible now?
No.
No. Okay. So we had a case of 12 years old female who was previously asymptomatic and developed pallor and syncope, necessitating multiple hospital admissions and blood transfusions. Stool examination was positive for occult blood. Upper GI endoscopy was done, which showed sign of recent bleeding. Then CT confirmed a large intraluminal polypoid soft tissue lesion. On upper GI endoscopy, there was significant intraluminal growth. Sorry. Yeah. Surgical exploration revealed a mass on posterior surface of the stomach, which was 10 centimeter proximal to the pylorus. A wedge resection followed by double layer of repair of a stomach was performed. These are the CT films and the endoscopic films. Intraoperative pictures. This is the histopathology report of the same patient. Histopathology was suggestive of just epithelioid type. Mitotic rate was reported as 11 per 5 millimeter square, and resected margin was free of tumor, and it was positive for CD117. Just is not that common in our pediatric scenario, but are there any markers or features to predict the clinical behavior in the pediatric patients? As unlike adults, mitotic rate does not appear to accurately predict clinical behavior.
Yeah, Dr. Pankaj, do you want to comment on that?
Is Dr. Pankaj around? He has messaged that he might leave early. So
Right now I'm here.
okay, okay.
So actually, the mitotic figure in most of the adult literature, if you search the mitotic figures, are one of the important part. Another part is like the size of the tumor. The size definitely make a one of the important prognostic marker. Other than we have in pediatric, most of the time they are the if you do their genetic workup, then you come to know whether they are imatinib sensitive or non-imatinib, like a SDH mutation or some other mutations is there. So I have also very limited knowledge about that, but what I have read about it, it is like a size of this thing. And definitely, if it is a metastatic, definitely it is going like this. If it is a rupture during the surgery, it is a high risk feature for that. And definitely, if you don't have the target for them, so then it is also make them a little bit of actually a poor prognostic marker. So Omkar, if you want to comment on that.
No, I think that's more or less. I think the size and the other factors also predict the risk of local recurrence more than the clinical behavior
Yeah.
during the course. So once you operate them, what are the chances of local recurrence are dictated by these features more than the upfront clinical behavior of the tumor. So yeah, so I think that's more or less.
Yes, sir. The thing is that, sir, that these are also very uncommon tumors in the pediatric setup. If it is in the stomach region, it is amenable to the endoscopy as well. But what if it goes beyond that in the small bowel, just say in the small bowel, just how do you suspect that the imaging features can be suggestive of just preoperatively? Are there any markers or, clinically, if we can make out that this can be suggestive of just?
Dr. Pankaj.
So if we have this thing, some radiology people with us. Otherwise, imaging wise, if you go by this thing, in pediatric, if I compare pediatric, MRI is now the preferred choice because of the low radiation. And though in adults the CT scan is there, endoscopy is there. In pediatric also the endoscopy you can see this thing. So they are the lobulated mass. If you have the history of this, and most common site is the stomach, and with a history of a bleeding per rectum or something, so then you can this thing. I'm not very much aware about the what you will get in a specific even in imaging.
So
just to answer your question, Dr. Saurav, most of these tumors are identified on endoscopy. So you
Yes,
usually
sir,
get it endoscopy and a biopsy, which we do more than the imaging, and I think that is also the better way to deal with it than the percutaneous approach, because that has a risk of peritoneal dissemination. So
no,
it
sir,
is we
that was
generally
not
get the
my
children.
question.
Yeah.
Sorry, sir. Sorry to interrupt you, sir. That was not my question. The most common site of just is stomach, I agree. Then the endoscopy has a play. But what if it is of a small bowel or, where you cannot insert a endoscope? I was talking about that particular region. For the stomach and the colon, we have the scopes. I agree on that, sir.
Yeah.
Yeah, Saurav, I have a comment.
Yes, sir,
Hello,
please.
Dr. Basant
Yes, sir,
here.
please, sir. Please, sir.
Yeah, yeah. Concern is that he just cannot be diagnosed without histopathology. Whatever you radiological imaging you will do, it cannot be diagnosed without histopathology or any marker. No, you have to take histopathology or go for surgery and take the whole specimen and examine it. And there is some finding who can suggest like that, but it is a very rare tumor, especially in pediatric patient, and it's very difficult for any radiologist to comment either on CT or on double contrast radiology or X-rays or ultrasound, or either it is endoscopic or it is a conventional ultrasound. What I want to say.
Yes, sir. Thank you, sir, so much. Sir, do you do any metastatic workup in a suspected case of just if it is on the endoscopy, the biopsy is confirmed? Basant, sir.
If biopsy is confirmed, then usually I don't go for that. But what literature says, you can go for PET CT scan, I think. But I am not sure about that. It's a very rare tumor. I have seen in adult gastroenterology, but I never operated on that.
Yeah, Dr. Pankaj, you want to make a comment on metastatic workup? So I think Dr. Saurav, you can just show that chart the way we diagnose. I think you're showing some chart after this. Am I audible?
So this can serve as a flowchart to have a work around the diagnosis of GIST. Omkar, sir, can you
Yeah.
pitch in?
No, I think this is a good depiction. No, I was asking you to show the one which we're showing after this.
Okay, sir. Okay.
Yeah. So these are the mutations and the role of I think we can cover that aspect, the tyrosine kinase inhibitors, a little later.
Mhm.
Yeah. Yeah. So Dr. Pankaj, generally, what is your approach? You diagnose something as just on endoscopy, USG guided biopsy, and with, of course, histopath. As sir rightly said, histopath is the backbone behind for a diagnosis of GIST. So generally, what is your approach to these patients?
Dr. Pankaj is left. Just sent a message. Dr. Omkar, you'll have to carry on.
Acha, so generally, as this chart is showing, the tumors which are resectable, we generally go ahead with the resection, and the one which are unresectable are the ones which generally come up with pose the most trouble. And to be very honest, these are so rare. I have 3 patients of just so far. And what we are dealing with as of now is the continuous recurrence which we see in them. And there is hardly any data to show the role of surgery in a recurrent disease. So this does become a difficult disease to treat if it is causing trouble to the nearby structures or anything. Otherwise,
So in your subset of patients in having recurrences, what was the most common cause that can be attributed to?
no, we will have to ask the experts in the field, to be honest, because this is something which we also deal very rarely with. So, and I think Dr. Pankaj has already left. Uh, Dr.
We
Basan, you want to
had a
have a comment?
couple of Yes, sir. We have a couple of patients who are in regular follow-up of
Hmm.
just operated of mainly stomach only.
Okay.
No recurrences so far. So since this chart includes the number of mitosis, but we have discussed that it does not significantly reflect the chances of recurrence. So what to see if we are going for a primary surgery? Having said that, if we have a negative margin, can we be reassured that recurrence won't happen?
No. So I'm Dr. Basant here.
Yes, sir.
Yeah,
Yes.
yeah. Even after resection, reported incidence up to 50% local recurrence if with negative margin. What is the negative margin? I have read only one paper because of your webinar. So they have reported 30 to 50% of local recurrence. These tumors are usually has good prognosis if it is in stomach, but has very bad prognosis in small bowel. If it is a intraluminal or extraluminal growth, extraluminal I can understand there might be a micrometastasis and that will recur in local area. But intraluminal, if you resect a 5 centimeter margin or 10 centimeter margin bowel with an osmosis, how it will recurrence, I don't know. Uh, Actually, something we need to read it.
Okay, sir. I was just wondering, sir, why I asked this question was the role of imatinib. So, if we are expecting any kind of recurrence or the high risk patients, can we start imatinib
Yeah,
empirically?
definitely. It is written in literature. If mitotic is more than 5, you have to give. In spite of what is the size of tumor, doesn't matter. A mitotic figure has a very high impact on overall prognosis. So you have to start that imatinib. But I don't think this chemotherapy available in my hospital or adult person are using it. So definitely they are getting from there.
Also, there are variants of just such as SDH deficient and uh, SDH competent. So, are they supposed to be treated differently, Omkar sir?
So surgical resection of the localized disease is recommended because of its indolent course.
Yes.
But again, extensive surgery and repeated surgical resection should be avoided in SDH deficient GIST. Now, you made a point about imatinib. I wanted to make a point there also that before we start TKI, imatinib mesylate, we generally always prefer doing a PET CT and so that the response assessment can also be made. And imatinib is used as first line therapy for most patients with KIT and PDGFRA mutant GIS. For
Yes.
patients with GIS which are characterized by PDGFRA, there is a variant. I don't remember exactly. I think it's D842V mutation. So there's a role of avapritinib, which is also used as a first-line therapy, and that has been shown. Of course, there are other TKIs which have been tried in these patients. But then the important point to make is that the PET CT is generally used for response assessment. Imatinib is not typically given to patients if they have KIT PDGFR wild type GIST. So that is important point because of high rates of resistance. So one should not consider imatinib upfront for all patients, but one should go ahead if in case we get a specific variant.
So that challenges a very resource limited pathology center in which
Absolutely,
if
yes.
if KIT exon 11 mutation has not been reported, then we might be ending up giving the patient imatinib in which it might not work at all. So, do you recommend that we must ask for the detailed pathology reports with all the IHCs in that?
Yeah, always wherever possible. And more than that, it should always be a tumor board reviewed disease, because there are too many ifs and buts in these managements. And hence, as a practice, we generally manage these patients in consultation with the Tata people, TMH team, in our institute, which is at Nair Hospital. So
Hmm.
we generally manage it with the consultation with Tata team. But then yes, there are again, I mean, multiple ifs and buts. So I agree, you cannot have this kind of a detailed review at each and every center. We have a backbone of Tata, so we can generally go with that. Agree.
Uh, Most of the doubts are covered with this discussion. I think we can conclude this session.
Yeah, Saurav, you can ask other public who is joining here. They want to make a comment on just actually what
Yes, sir,
Dr.
please.
Omkar is saying, that absolutely fully agree with him. Surgery
Yes,
is the backbone of this treatment for this. But chemotherapy should not be given every cases without histopathological evaluation. So
very true, sir.
any senior person in group or chat box, they can ask questions or give suggestions.
Anyone in the house would like to make a comment or share their experiences? Dr. Shalini ma'am, Dr. Sareen sir is also there.
Dr.
Okay,
Salne
so
should speak. Yeah, sorry.
I think we can conclude the session.
Yes, I think, and as far as GIST is concerned, because it's so rare to have it in children, we usually take help from the adult colleagues. Because I haven't seen any GIST in a child so far.
Yeah, so true.
So ma'am,
Because
even
we
yeah,
generally see, an adolescent female with coming with gastrointestinal bleed. That is the only cohort of patients where I might suspect GIST also. So otherwise, as Madam rightly said, it is generally the adult work, and we don't deal it so commonly.
okay. So
Yeah, and the
even when I was in
discussions were
TMH,
very
I've
good.
not seen any direct patient. Yeah, discussions were very good. Even I didn't see any gist in TMH in pediatric side. So I really wanted to know what was the experience of the audience. And it was, thank you, Dr. Omkar, Dr. Saurav. It was really nice session. And thank you everyone who could join. I think we can conclude the session now. Is it, we are fine, Dr. Saurav, Dr. Omkar?
Yes,
Yeah,
ma'am.
yeah. Thanks,
Regarding
thanks, Dr.
the
Monica, and to the
Yeah,
team.
thanks a lot. Thanks a lot. Thank
we
Ektrasetu,
will
you.
yes.
be discussing gonadal tumors. It was scheduled for today, but due to the time constraints, we cannot do that. But
Yeah.
we will have
We'll
this
do-
in the next meeting.
Sure.
Yes. Thank you. Thank you,
Yes.
everyone. Thank
Yeah.
you.
Thank you so much. Thanks everyone, to all the panelists. Thank you so much.
Thank you, sir. Thank you,
Thanks,
ma'am.
Saurav.
Thank you
Yeah.
so much.
Thank you, everyone. Thank
Thank you.
you. Thank you, Dr. Monica.
Yeah. Thank you so much, sir.
Thank you,
Thank you.
Omkar sir.
Yes.
Thank you all for the wonderful session. Now allow me to end it here.